1 iota in cross section. Here it is at least 3 iotas in cross section in size. So you can see the 4 pulmonary veins, especially the 2 inferior pulmonary veins you are seeing here. They are not going into the left atrium. Instead, they are going into the right atrium. Can you see the pulmonary veins draining into the right atrium? But I want you to appreciate one subtle findings which we always overlook in this case. If you see the right atrium versus the left atrium. Overlooking, you will feel the right atrium and left atrium are of the normal same size. But if you carefully look now, the left atrium is slightly smaller. Is the subtle change? Can you appreciate that? Start observing the subtle change. Can you see the subtle change now? Friends, why don't you all come in front? We can have a discussion. Come all of you in front. So that, see, everybody thinks that these 2 atriums are of normal size, right? Is this atrium of normal size? Yes or no? They look of normal size, right? But if you carefully look now, you can see the left atrium is slightly smaller than the right atrium. Never neglect these subtle signs in video. You may think everything looks good, but if you carefully look now, the left atrium is smaller than the right atrium. And that should give you a clue, like that, a tiny iota, slightly tiny iota, slightly tinier pulmonary artery, slightly tinier left ventricle, right ventricle. Your eyes should get tuned to that. See, just go through the video now. Your eyes will think left atrium and right atrium is of normal size. Am I wrong? Okay. Now, in a busy practice, you will think everything is normal. But carefully, if you see now, you can see now that the posterior border of left atrium and so many things, whatever I told you, is showing the pathology. So, these subtle things, did you find the subtle things now? What is the most important subtle thing I want to tell you here? See, wide gap is very clear and this is round. But one subtle thing what I want to show you, the left atrium is slightly smaller as compared to. Is the subtle thing you can appreciate now or is it difficult? I want you to train your eyes in subtle pathologies. That's how you will identify. Okay. So this is how you should train your mind on these subtle pathologies. One more thing can you find? Okay. See, what are all the pathologies you are seeing here in this case? One is the gap between the posterior is more. It is rounded. It is not linear, everything. But one subtle key pathology which is striking, can you guess? Prominent coronary sinus. Okay. Prominent coronary sinus. See. Myocardial? Hypertrophy. Yes. Excellent. And one thing I wanted was the width of the heart equal to the length of the heart. Is this eyeballing now? You will train your eyes? I know new virus I have given you. But such viruses, will it strike again and again? The width of the heart equals the length of the heart. That means there is some cardiac remodeling, some failure, some issue will be there in the cardia. Okay? So these are all the subtle things which we want you to appreciate. Okay? Now, this was the case I showed you. So, see, I don't expect you to see these subtle things. What is the subtle thing you are seeing here now? One nasal bone is small as compared to the other nasal bone. Okay? Tiny real space. Okay? Two to this one. All this, whatever we saw just now, all these subtle things are okay, but textbook wise. But what happens? Your mind should get tuned to seeing the chamber size. Okay? Only then you can appreciate. See, now appreciate the left atrium. Okay? As compared to that image now. Do you find this left atrium is normal? That left atrium was slightly smaller. Any doubts about my tiny approach? So these things are very, very, very key in future learning and approach to the pathologies you get. Okay? I will give a brief idea about the outflow tract pathologies. Outflow tract pathologies are of two types. Normal crisscrossing present, normal crisscrossing absent. Two outflow tracts are there, only single outflow tract. So these are very difficult, right? Because imagine you have a common arterial tract and pulmonary artery is arising out of it, and it is also very narrow. Then also the pathology is same, no? So when you get a single outflow tract, look at that outflow tract. If the outflow tract is completely blue, think of truncus arteriosus. If that outflow tract has a red phenomenon with the blue, then you may not see that pulmonary artery, but you will get some ductal arch behind it, below it, tortuous. So if you get aliasing in that blue flow, suspect pulmonary atresia with VSD. Okay, it's extreme type of tract. So whenever you get a single outflow tract, but no aliasing, suspect common arterial tract. Whenever you get a single arterial outflow tract, but with aliasing, suspect pulmonary atresia with single type of. So that I will not discuss because it is very easy. I will discuss in depth now how to differentiate a TOF and TOF type of devolving. Is this differentiation important? How to differentiate a TGA and a TGA type of devolving. Shall we discuss these cases now? So H start from hepatic and go up to the thymus and start looking at all this minor pathologies. You will start appreciating and evaluating it better in your practice. Okay. Now, before I go into my outflow tract pathologies, I want you to be very good in extracardiac evaluation. See, this fetus had horseshoe kidneys and this fetus had coarctation of aorta. And this coarctation of aorta, can you see this coarctation's slight slender aorta there? See? What is happening here is, that is called the coarctation shelf. Okay. You can see the LA. My video is not running. Okay. You have got a small LA, small LV, small outflow tract, and you have got this coarctation shelf there. Okay. So that's a typical. This was. A brief word about coarctation of aorta. What I want to tell you is, if there is a VSD stealing the blood into the aorta, the whole of the aorta will be narrow. If very less blood flows into the aorta, imagine there is a TAPVC. So the amount of blood in the aorta is less. Why? The venous return goes to the right side. Imagine there is a right atrial aneurysm. The foramen will flap aneurysm. That will get less blood into the aorta. Imagine there is a PL SVC but there is no right SVC. Then very less blood flow will go to the left side. They all will cause tubular narrowing of aorta. Imagine there is an aorta and a ventricular septal defect below the aorta, and the blood is going to the right side, very less blood is going to the aorta. So there is tubular narrowing of the aorta. Then there is second type of narrowing of aorta, where only at this segment of aorta you get a narrowing. You get normal ascending aorta, arch of aorta, but at the junction of the isthmus of aorta, the muscles which should lie over the ductus arteriosus will migrate towards the aorta and create a constriction in the aorta. So there are two types of aortic stenosis, coarctation of aorta. One, the whole tube of aorta is narrow. Second, that is called the hemodynamic theory, where the blood into the aorta itself is very less. The second theory is called what? Muscular migration theory, where the muscle intended to cause stricture of the ductus arteriosus. That muscle will migrate into the aortic isthmus and will cause a narrow segment of aortic isthmus constriction. So this is that second type of pathology where you are getting constriction of the isthmic portion. So That you should be aware. In those conditions, LA and B will be small. All these are videos. I don't know what has happened today to all these videos. Okay, fine. When you get a outflow tract like this, when you get a small aorta, when you get a small pulmonary artery, whatever the outflow tract, your mind should go into the hemodynamics. Okay? And without these hemodynamic applications, you will start finding it difficult. And in this coarctation, there is a bicuspid aortic valve, and there is a bicuspid aortic valve, and it is so tiny that unless you look for it, you will not get it. Because early in gestation, you cannot make out. But look at the closure line. The closure line is not in the center; it is at the periphery, and the aortic valve is slightly thick. Okay, and a tiny thick aortic valve. Now, can you see the descending aorta, and can you see a shelf there? Contraductal shelf. Why I am showing you this is not to understand coarctation of aorta. To understand one important thing. What am I doing here? Why did I get an image like this? I want you to paint the vessel on me. So I have used what modality? How I have picked up? And I have used in this Voluson E6. How many years back I have done this study? 2014. Any machine you take will give this pathology, will give this quality. This is the Voluson E6 of how many years back? 2013 Voluson E6. Okay. So 2014 I have done this scan. And I want you to learn one secret here. What happens? I play with the wall motion filter. I reduce the wall motion filter so I get alias. Then I slowly increase the wall motion filter and adjust the balance. The color balance such that it should fill only the vessel and it should not spill into the other structures. You are understanding the two important things what I do? I reduce the PRF, I get alias. Then what I do, I increase the wall motion filter such that I get only the flow. Then I get still bleed. Then I play with what? Balance. So playing with balance and playing with wall motion filter and playing with PRF. And in the first trimester, I play a lot with the power. The power I keep at 70, 75. Okay? Thin patients I keep at 80, 85. Obese patients I keep at 100. So the amount of power, amount of PRF, amount of balance, amount of wall motion filter, all matters us to get an image. See, if we can get an image in a 2013 E6, I think all the technologies are now about this thing. Okay. So my request is, don't complain on the machine. Any machine, if you can know the physics, if you can sit with the application specialist, you can also get this. That is why I am showing you this video. Not to show that